folks, and we are about to start another installment of Risk Unfiltered. And I'm so pleased to have as our guest, Dr. Ryan Paul. And as per usual, I'm not going to introduce Dr. Paul. I'll ask Dr. Paul to introduce himself and tell us from whence he came. And we'll start, lacing in with some questions. Dr. Ryan Paul, welcome to Risk Unfiltered, sir.
Thank you so much, Ken, for having me. I appreciate it.
So tell us and the listeners, who's Ryan Paul? What's your background? What's your specialty? And where are we going next?
Where are we going next? Well, like you said, my name is Dr. Ryan Paul. I am an infectious disease and pharmaceutical epidemiologist by education, but I've always been a healthcare entrepreneur, primarily a social entrepreneur. And we can talk a little bit about that in a second. And I think we can lace some of the things that we're doing around the world into that. My background is kind of all over the place. My grandfather was an early executive at Eli Lilly. He was a pharmacist by trade. He was one of the first individuals in the late 40s to start installing pharmacies and specialty pharmacies and infusion pharmacies specifically, and sterile compound pharmacies that produce gels, infusions, and injectables on site at hospitals and health centers and within medical arts buildings. It was just not something that had happened until really the late 40s, early 50s. He built that into a national pharmacy chain, primarily centered around the Midwest, called the apothecary shops. And that entire patient book across the Midwest was really how Rite Aid started in the year 2000. Okay. And then obviously a lot of listeners know that Rite Aid was acquired by Walgreens. Right. And so I was around it. Right. I was around pharmacotherapy, pharmacovigilance, everything all the time. My grandfather lived and breathed pharmacology.
So I guess that's a genesis and the
it really is.
Yeah. And so you're actually continuing in that space for the most part, eh?
Yeah, we continued in that space. I mean, I think that it was always unique. I did not intend, to go to graduate school, much less go to med school. I had no aspirations of that. Honestly, I went to business school. I grew up in privilege. I wanted to make sure that I could continue to provide the life for myself that I had been provided for as I had grown up. But as I got out into the world, I realized that the world that I had been presented with over the 18 years of my life growing up in a very sheltered community, that the world was very different than what I had been exposed to. So as I had kind of grown into who I was, I had worked in managed care channels, working for Blue Cross Blue Shield, working for pharmacy benefit managers. And what I recognized is that my personality, who I was, that thing inside of me that I always talk about, that urgency, it just didn't fit in what I was doing. So I went back and got a master's degree in global health. And I actually thought at that point I was going to end up with an international NGO. I did. I thought I was going to end up in the global South, in the majority world, working and doing something. And there was this unique opportunity. It became very vogue to start doing direct contracting in primary care, specialty care, and hospital care in the employer self-funded world, So hospitals, health centers, surgical centers, they were all contracting directly with large self-funded employers, because what self-funded employers were starting to realize is that it was actually less expensive for them to just pay claims directly on behalf of their employees to hospitals, health centers, and other medical practitioners than it was to pay for self-funded claims through a third-party administrator and let the Blues, United, Cigna, Aetna, and Humana's of the world rip them off. And so what I said was that there was this great opportunity to kind of capitalize on this vogue kind of direct movement. And so I created a program called Direct Pharmacy Care, where I took federal drug pricing program related hospitals and health centers, or in organizations called covered entities, and I partnered them with large health plans, right? So that specialty medications could be sold direct out of the hospital. It would create a massive amount of specialty medication savings for these health plans, but it would actually drive a significant amount of new revenue to these not-for-profit hospitals and health centers related to very high-cost medications, creating a bigger fund for uncompensated and charitable care. I got about five, that company was called Health Clarity. We got about 5 or 6 years in, private equity came in, we got really big. I think we had about just under 350 employees. We were operating specialty pharmacies and programs in 36 states. And the mission just got lost in all of it. And I would say at that moment, it was kind of at the beginning of the pandemic. I have a totally other backstory that, maybe some other time we can talk about.
Let me ask you this question though. So social entrepreneurship. So for the listeners who may not know what that is. So when did you decide that Rand Paul will be a social entrepreneur, or what made you decide? I mean, you always had that sort of function built in, or that capability built in, because when I chat with you and in the essence of full disclosure, I know Dr. Paul on a personal and professional level. You are a consummate business person. So oftentimes I'm chatting with you, I threw out the doctor prefix, right? Because I look at you as a colleague, as a business person, as an entrepreneur, right? So what is a social entrepreneur?
So the pivotal moment was right when you were asking that question.
Right.
And I think I can answer both questions at the exact same time. What is a social entrepreneur? It's an individual that believes that business doesn't have to be about capitalism. Business doesn't have to be about a profit-driven motive, right? I say a lot, right? There's nothing wrong with in healthcare. We'll just talk about healthcare specifically. There's nothing wrong in healthcare with an individual being paid incredibly well to bring value and healing, right, to communities, to societies, and to systems.
Right.
There's a fine line between that and profit-driven motive, right?
Right.
Even if you're talking about residual income, right? I mean, I always tell people, like, when you're an entrepreneur, you have to decide, am I starting a business to give myself a job, or am I starting a business to actually own a company? Right. Because those are two totally different things, right? I want to be able to wake up in the morning and know that if I don't want to go to the office, that I'm still going to be able to feed myself and that my organization is still going to be able to operate. That's kind of the crux of it. So for me, I had built a very large multi-million-dollar organization, and private equity was involved, and we were cranking. We just were absolutely cranking, but I wasn't happy, and we were not fulfilling the mission. And that's when I recognized that I had to not only make some radical changes personally, but I had to make some radical changes professionally. And that was selling Health Clarity and redesigning Holden Fitzgerald as an asset company into a global public health practice that had assets and resources to deliver to vulnerable and marginalized patient populations. But more importantly, to kind of like uncumber myself from the idea that my legacy was going to just be, if I can just put it, a rich white guy. Like nobody's gonna show up at my funeral and be like, you know what, he had money. He had money. Like nobody gives a shit about that. Nobody really gave a shit about me. And anything that I thought I was doing to have impact, to increase the amount of funds for uncompensated and charitable care in all of the hospitals and health centers we were working with all over across the United States. The measurement was this: all of those institutions were spending less than 7% of that money on actually taking care of people that had need, which continued to tell me that we were not there yet in the US healthcare system. And I needed to figure out a way where I could be genuinely who I was every single day, be able to speak my mind, know that I don't have to be honestly, I don't want to be a fucking diplomat. I'm not a diplomat. I don't care if people want to do business with me. It's just one of those things.
Part of what you're doing is, especially in the public health space, is acting as a diplomat. And to that, I mean, you're doing work or you're getting involved with work in Africa, in the Caribbean. We'll get to that in a second, but let's touch on the 100-pound gorilla in the room today as we speak. Jerusalem and Gaza, Israel, Gaza, that war. From a public health, and you mentioned the words vulnerable, marginal population. What do you see as specifically, we're not going to get into the politics of it specifically, but from a public health perspective, what's the impact across the region and across the world? Because I'm thinking, and I love using this word, and you corrected me on the pronunciation, risk homeostasis. I would have said stasis, and Dr. Paul in the public forum said, Ken, it's stasis. Okay.
No, I don't know. Did I actually say that?
Yes. So don't even go there. Yes, and
that's
so
funny.
Pronounce it risk homeostasis. But what do you see the impact on public health given what's going on with this conflict? And you know what? Let's make it a little bit more general. Causation or correlation, conflicts or wars, public health. Causation, correlation, wars, public health. Speak to that. That's a heavy question.
You're right. It's better to keep it general.
Yeah. But causation, correlation, wars, conflicts, public health.
Well, yeah, I mean, if you're talking about conflict,
you think of
or
Africa
any type of
as well,
fragility,
so bring Africa into the loop.
Right.
Yeah.
I mean, if it's autocratic issues in West, Northwest, and in MENA,
right,
or if it's Gaza, Palestine, Jerusalem, West Bank,
right,
it's happening all over the world. Correlation and causation. It's really about it's about access. I mean, unfortunately, in the current conflict, many folks didn't have access to healthcare anyways, right? I mean, there's just a limitation to having access to medicines, to basic necessities, basic needs, and that's really a lot of times the issue. But if you're talking about just delivering healthcare in conflict zones, or what war does in those types of scenarios, it's really about infrastructure and about understanding that you're going to have to take a step back and take a much more emergent approach to, or even an archaic approach to delivering medicine in those scenarios. I think that above all, when this, I mean, in the literal sense, when the smoke clears, you have individuals that are ultimately going to lose their lives because they're not being able to be treated for things that are non-communicable. Folks that are just not getting the services they need because they have chronic disease that's not being treated during the course of that time. You have obviously infrastructure that is going to produce infectious disease, vector-borne disease, that maybe would have exposed itself under normal circumstances. In this particular scenario, what's going on right now, there's just absolutely no way to get relief to a lot of those folks. I'm pro-people. I am pro-truth, as I have said many times. And when it comes to public health, it's really about, for them, it's going to be about balancing, what is humanitarian aid. So if we look at, are there going to be resources that are going to be pulled away versus pushed into over the course of this conflict? I mean, we know that Biden is looking at kind of bundling Israel and Ukrainian relief. There's a lot of debate about whether or not that's a good idea. This is what I would suggest is that quite frankly, everybody's chosen sides. And when you look at the global and public health community, we're not trying to choose sides. We're just saying there's a lot of innocent people that aren't going to be able to have access to care. So when the smoke clears, as I said, I am more concerned about mental health care. I'm really more concerned about the way in which violence continues to propagate itself as a result of resentments, or the origin of that, which is resentments, which is community angst. you know, there's just going to be a host of issues that are going to come out of this particular issue, as we've seen. But again, a lot of this isn't new. So even if you want to draw it down into some of the local civil conflicts that are happening, whether it's guerrillas in South or Central America, or if it's militias in autocratic parts of Africa, we have to remember that most of these people don't have access to medicine and healthcare to begin with. So the idea that we now have to then structure a system of delivery almost feels a little too late. So it's going to be UN relief, the Red Crosses of the world that are going to be coming in and providing that direct relief and humanitarian aid. It's kind of like saying, hey, the US, the only time that someone actually gets healthcare is when they're in county jail, right? You know, so I think that, you know, those types of situations are kind of sticky, right? But the reality is that war is going to simply say, you're going to lose infrastructure, you're going to have drug shortages, you're not going to obviously be able to have primary care type of delivery systems like you normally do. Everything is going to be based on an emergency. So most of it is going to be medic-based healthcare delivery.
And then the long-term impact of that will be as we know. Let's speak about the work Holden Fitzgerald is doing and plans to do both. And we'll pick the vulnerable and marginal communities of Africa and the Caribbean. You're doing work. Holden Fitzgerald is doing work in Africa predominantly right now. Yeah. Why don't you talk a little bit about that, and how do you then, or what are your plans to doing the same thing, if not as good or better, for the populations of the Caribbean? But let me ask this question. Let me go to the Caribbean, and if I were to put you on the spot, and you're very open, honest person when it comes to the state of global public health, what would be the number one issue from Dr. Ryan Paul Holden Fitzgerald's point of view? What's wrong with global public health as it stands today? What's not going right and needs to go right for that, for the furnishing or for the providing of good public health? What needs to go right?
Well, I guess we're reaching a new audience today, but obviously I talk about it a lot, and I always say I'm going to die on this hill, because by myself, there's just, I'm not going to be able to show up and say, stop.
Right.
It's international and foreign aid disguised as philanthropy, charity, or some type of infrastructure building to create or necessitate national security within a country in the majority world. It just, that in my opinion is the number one issue in most places. In Africa specifically, I think the Latin America and Caribbean, different issues. But like, if you look at globally, it's why do we continue to pump billions? If you're talking about Europe and North America, right? Just why are we after decades of pumping what is now trillions of dollars into health systems, we continue to see that those health systems are not self-sustaining. There is no circular economy. And the only places where you actually have any level of world-class health centers are where you have a monopoly of Fortune 500 companies that have come in and placed themselves in type of metropolitan areas and are serving a very small population of foreign nationals, expatriates, and the very, very small percentage of wealthy individuals in those countries. So I think that there's a million different ways to answer that question, but I think it's more.
How do you fix it then? So we know what the issue or the risks are. Is that fixable? That issue that you're raising? Is that
so I mean, we can only do it one institution at a time. And so the answer is it is, because there is money, right? It's not like there's just no money where there is economic disparity. There is money in countries with significant economic disparity. So it starts with, it's no different than what I talk about when we talk about antimicrobial resistance frameworks for protecting societies. It first starts with leadership and governance.
Yeah.
And understanding that healthcare is a public utility and it should look very similar in the way in which we make decisions about it, like electricity and roads in general national infrastructure. And so I always propose that you look at it through that lens. And that doesn't mean you have to have a wildly 100% socialized system. Quite frankly, there is no such thing as a pure socialist healthcare program in the world. It just doesn't exist. So when people say, oh, well, we don't want socialist, in the US, they say they don't want socialist medicine. They say, well, that doesn't really exist. So unfortunately, there's just a lack of education. So how do you solve for this is public-private partnerships, getting leadership in the government space, primarily in the Ministry of Health space, that are educated to have a level of entrepreneurial spirit for innovation. Because right now it is, we show up and they say, we need funding to be able to do this. And I've said, well, you've been asking for funding for the last 50 years for the same thing on somebody else's fiscal budget. And you're not actually solving the problem. You're literally just taking someone else's money, spending someone else's money, and then waiting for someone else to give you money. That's not a solution. So our goal, and we've radically changed, and I'm excited about it. We've radically changed our model November 1st. I mean, we have a new website coming up. Our brand is staying the same. Our mission is staying the same. The way in which we're going to deliver services is going to be radically different, because what we've identified is, it's interesting. We're on average, 75% less in fees, consulting or advisory fees, 75% less than the average management consulting firm that's being paid by international and foreign aid to work with an NGO or a Ministry of Health in the majority world. Unfortunately, we have trained folks, at the university level, this is what happens. At the university level, we train them to believe that they're going to go and work for an NGO or a public health institution that's going to use somebody else's money to fix the problem. So we're not actually training public and global health practitioners to be business people, to say, like, if nobody's going to show up and give me anything, how am I going to make whatever it is I'm good at work? And so a lot of what I do with our advisory team that has come from incredible places, UNICEF, USAID, World Bank, management consulting firms. The first thing that I do is say, how do we take the things that you're really good at as a scientist, as a global and public health practitioner, and translate that into a value proposition that makes people believe that you're actually worth what's coming out of your mouth? Because here's the thing, when you worked for the organization over here, they were paying you 1% of what they were collecting in funding to have you work on their behalf. So what would it look like for you to have kind of a similar vision to me and build your own practice in country that looks very similar to what we're building on a global basis?
Interesting.
And I think that if these folks are having that conversation, then the paradigm changes, so that leadership at these hospitals and health centers, the folks that are starting new NGOs, like, for instance, the Bethel Okiki, who's a part of our vaccination program in West Africa, he has a small not-for-profit. And immediately it comes to my brain, November 1st, we are launching a worldwide group purchasing organization, right, that is attached to a captive insurance, a sovereign risk management program. It's called the Holden Fitzgerald Health Trust. It will operate in Latin America, the Caribbean, and in Africa. And simply put, we have basically created a supply chain that allows everything that you could possibly need in pharmaceuticals, from specialty medications, limited drug distribution, your normal maintenance medications and generics, antibiotics and vaccinations, as well as durable medical equipment and capital equipment for actually, doing sterilization for pharmaceuticals. And then an entire new tech division that will actually build and create data aggregation systems. So no longer will these countries have to worry about technology, because if you're a member of our GPO, we'll give you all of the technology that you need for absolutely free for being a member. And we can aggregate all of this data into one clearinghouse and actually give countries and public health institutions and hospitals and health centers the ability to actually own their own data and stop letting foreign national companies monetize data on their behalf and then give them no benefit. And then the third piece is that if you're a member of our GPO, you can either get advisory services at a cost differential of cost of living reduction against USD, which means a place like Tanzania is now going to pay 62.78% less in consulting fees from our minimum. Or if you are an institution that is actually using our supply chain management and our GPO model, we give our advisory services for free moving forward.
I like
so
that.
We're radically changing the model.
And that's great. I like that. And in the essence of full disclosure, you know, I'm definitely going to get involved with some of that. But does that require Holden, Fitzgerald, Dr. Paul Ryan to have conversations with, what is it, the NGOs or the local Ministry of Health in the countries that you will be working with?
Yeah, so I think that it's very dynamic.
Right. Yeah, exactly. So how do you get to the point where this where you are accomplishing that goal? Is it in partnership with or in collaboration with the ministries of health or with private institutions? How do you get to the point where the goal, the objective is being achieved as you have just outlined it? How do you get there?
Where we have seen it to be most effective, and again, for your audience, public health does not mean government employees providing public health. Public health is what it is. I mean, we won't talk about what public health is specifically, but public health is the way in which we deliver, or the mindset of the framework of policies, procedures that get deployed to take care of the health of the public. Which is a little bit different than even population health and managing populations globally in communities.
Right.
So,
and thanks to that,
where we're having success is getting folks from both the public and private sectors to have that conversation together, right? So another part of the new launch is we have our new Health Equity Collaborative. We have our new Population Health Management Collaborative for providers. Our Health Equity Collaborative is for folks that are going to be working, that work specifically in community and government agencies. And then our third piece is our Innovation and Research Collaborative, specifically for, our immunologists, our virologists, our epidemiologists, the folks that actually want to collaborate together. So what we're doing is we're building communities within communities to have these conversations. So it is multidimensional when we say, okay, look, we need decision makers in country, right, that already have a level of influence at the government level or at the Ministry of Health level, because Ryan doesn't. Then we're going to say, okay, do we have the resources today on the ground, and what does Holden Fitzgerald need to bring to bear on that? So the way in which the Holden Fitzgerald Health Trust is set up moving forward is we own, in partnership with whomever qualifies for our health trust program, the GPO model, meaning that we're not just coming in and setting up shop as a foreign national and saying, hey, we're going to do this. Well, we actually have an incredible qualification process. We're an institution, and we actually have 2 institutions that have just qualified for it, where they are either as trade associations or they're large for-profit and not-for-profit institutions that are already working in public health and the pharmaceutical supply chain space that have said, yeah, we want your resources. We qualify them, then we bring them in. These folks already can bring all of the decision makers to the table. So in one country, we literally just had a conversation with in-country manufacturers versus foreign manufacturers. And where there could be both in-country or import and export relationships for raw materials. have the conversation with the Ministry of Health, have the conversation with the regulatory bodies that are necessary to be able to create these types of partnerships. And then essentially what happens is that these institutions become a franchise. Essentially, it's not really a franchise model specifically, but it kind of feels like a licensing or a franchise model to operate that health trust on our behalf in country. The goal of that is twofold. Number one, to create on the ground ownership, right? So we're not just coming in and going after somebody's business, but to create a collaborative effort, but also to create some assurance that what the capacity that's being built can be owned locally, so that it is creating that economic stability. I always tell people, look, the reality is that healthcare gets paid for with taxes. And if there's not a tax base because people aren't making money, then there is no system. And that's just everywhere in the world. That's not the US. That's every universal healthcare system that is working really well today is being paid for by taxes. Right. So if you don't deal with the first layer, which is like healthcare is an entire segment of commerce, and you're not going to build, economic development just fundamentally in that space, then you've lost before you've started. Yeah. So part of the community health anchor strategy, this place-based approach that we take, is about creating an ecosystem where public and private partnership is incentivized so that a circular economy can happen both at the local level, at the provincial level or the state level, and at the federal level or the national level. At the end of the day, healthcare is always delivered locally. And so sometimes we forget in our pursuits from a policy perspective that we're going to create a national health scheme, that we forget that the actual service of providing or delivery and design of services for medical and pharmacy are happening locally. They're not happening. So all of that gets lost, right? It's why the national health system in the UK is struggling right now, right? Yeah. I mean, they're literally having a conversation about ruining what has been a sovereign and solidarity based system for decades. Yeah. And they're gonna pull in, what is seemingly looks like the US system because that's a good idea. Right. So again, I then come back and say, okay, well, then let's look at who the players are. Who is building your hospitals and your health centers and your adjudication systems for claims reimbursement, and who is building your EHR? What you'll find out is that even in the digital health space, as we've talked about before, the players that are innovating, number one, have no idea how to actually get what they're building to create impact. They just think if there's users or adoption, it's working. And the answer is it's not. But what we find is that the majority of the organizations that are behind the organizations, and sometimes it can be 2 or 3 layers, it's the very institutions that have built the US healthcare system that is fleecing Americans. Like the reason why people can't afford think about it, $28,000 a year for a family premium. Yeah. Like it doesn't matter. Like unless you're really rich, you cannot afford $28,000 a year.
How is this message resonating, Ryan? I mean, you're a consummate salesperson, and like myself, we have to both inform, educate, and sell. That's the reality of it. Yeah. So how is your message being received? That which you have just articulated to us. I would expect that you have to speak to the decision makers. Are they kicking you out the door? Are they saying, well, yeah, I understand what you're offering, let's partner? Or are you getting a lot of resistance then?
So I've always considered myself to be someone that's really great at qualifying opportunities. Okay. I have changed my model. People 100% know whether or not they want to get on the phone with me now, way before they've actually met me, just because of the way in which I've built my organizations over the years. And quite frankly, I make sure that Enoch, our chief development officer, and our directors and associate directors in country are very clear that if you're going to get Dr. Ryan on the phone, right?
Right.
He is going to be very straight with you, and it's out of love and respect. It is not out of anything other than that.
Yeah.
And so what I would say is that I'm not having conversations with folks that don't have a desire to drink the Kool-Aid.
Okay.
Now, I'm not saying that everybody, I mean, I would say like 3 weeks ago, I had somebody.
How do they get the Kool-Aid though? So they would have to know not just about Ryan, Dr. Ryan Paul, about Holden Fitzgerald. They would have to have the information that you have just articulated. So how do they then know that this is what, is it by a marketing plan? How do they know what your plans are? How do they get that? How are they getting the information?
Well, I mean, I guess, yeah, I mean,
how do you get it to the decision makers before they have that conversation with you to say, yeah, we on board and I have certain questions? What's your marketing strategy? How do you get, because you aren't, I don't know if it's, I really don't know how it's getting across to the folks, but how are you?
I don't know either. I think it's just like,
because you have to have a transference, yeah. Because I'm 100% with you. We have had conversations before, and as I just alluded to, you sell the product, the aspirations well. How do you get that in the door so that they can say, yes, let me go call Dr. Ryan Paul in furtherance of what you have just said there? How is that?
I mean, we had, so you know that's probably 3 different ways. Number one, the global network that we have.
Right.
It's not just the 28 associate directors and directors that we have that are placed throughout Latin America, Caribbean, and Africa that are communicating the value proposition. But I can tell you, you know, we had 18 of our team members on a meeting today, and I was actually right before that I got in with you, and my message to them was do not conflate who you are, your value, and why people should work with you individually with our product and service offering. And then what I asked them to do, which they will do, I said, in all of your markets, I want you to identify 10 organizations that we can bring into our GPO the first month of November for little to nothing, and give them value immediately. And so by the end of next week, I guarantee you that between West Africa and some other parts of the sub-Saharan, I will have about 75 meetings set up over the next 3 months with hospitals, health centers, and NGOs that do purchase pharmaceuticals, DME, and other capital equipment. So some of it is just good old, you know, roll up your sleeves, get on the phone, and just let people know that we're here to do these specific things. Now, things have changed for us, so there is a little bit of a slowdown right now. What I would say is that we don't have huge engagement on, for instance, our Global Insights blog, but our unique views and the amount of contacts we get after I just post something, we get about 75 contact form filled out on the Holden Fitzgerald website. 50% of them are folks that want to work with us. The other 50% are NGOs, government agencies, and other healthcare institutions, primarily private, that want to either have a strategic partnership, want to talk about market entry, or actually need help. So a lot of it is, I can just tell you up until this point, and again, Holden Fitzgerald and who we are today, we're relatively babies at, as far as like this. The other piece is we've decided to do a lot more inbound marketing, right? And that is simply value content out, but the value content out can't fully be received without you giving us your information, right? So from a business perspective, we're just collecting information. Right now, we have I can tell you in the last 6 months, we have over 75,000 public health practitioners that have voluntarily given us their information via our website. It's wild.
Yeah, that's
I don't,
a big number. Yeah.
It's huge. Sometimes, just like if you think about personally, yeah, I mean, do I say some controversial things that just get unique visitors? I actually get more people telling me they disagree with me, and then finding out, and then 30 days later coming back and saying, hey, what do you think about this?
Yeah.
And we've come to the point where like Enoch and Anna, and our director in West Africa, Gabriel, they're kind of the gatekeepers now, because, I'm the one that I want to be a part of every conversation. I can't be, I can't be right now as much as I want to be.
Right.
And so we're just getting a lot of inbound traffic because of the conversation that's been having, right? Because really, well, I'll give you an example. I did the podcast with Planetary Health, right? And we talked about unmasking postmodern colonialism and global public health, right? Like you would think like, there wasn't like huge engagement. Well, I mean, there was 60,000 unique viewers that lasted more than 10 minutes. So they heard it, right? They heard what the message is. And so like, for as much as there's GPO and technology and advisory services from everything from social programs, federal healthcare, and climate and resilience, it's really the message is singular. The message is, every time I go to the bank and ask for a loan to start a business, do I own that business? Answer that question.
Interesting. Yeah.
Every time I go to get a mortgage and I go to buy a house, do I actually own that house? Every time I go to an international aid organization or a foreign fund, or I go to the World Bank, or go to UNICEF, or I go to a foundation, or I go to an endowment, and then I build something with it, do I own the thing that I built? Every time an institution pays for a digital health platform or an EHR platform so that we can do good clinical work, do I actually own the data that's going into that system? The answer on all of those things is absolutely 100% no. And so this is about, it's about this idea that although we live in a global society, and I am a globalist, and I just am, there has to be a level of sovereignty, solidarity, and autonomy as it relates to healthcare, because cultural systems have to drive it, right? I mean, the bottom line is that Ayurveda in India is an incredibly effective way to deliver healthcare. Like we don't need US healthcare operating. We don't need that, right? Like we don't need that in most of the world, because number one, culturally, it doesn't make sense. And number two, the health issues are radically different, right? Radically different. Think about the blue zone and just the way in which folks in the blue zones eat. Radically different than the processed foods that Americans eat. So it's so individual that we have to be really careful about this idea that we all have like we've got the solution, right? Like we've designed the solution, and if and this is, everybody just needs to follow this map. Because I call it's not true, because the bottom line is that everything that I've struggled with in my life, I've had 100 different people come to me and say, Ryan, I can help you with that. I can help you with that struggle. Guess what? It took me 25 years to deal with some of the issues that I had in my life. So all of these brilliant people that had brilliant ideas, right? I mean, it didn't work.
Okay, let's end on the Caribbean. My place of birth, though I live in the US, I've been living in the US for many, many years. And by the way, welcome to quasi-Caribbean life with your move. We wouldn't tell people exactly where you are now, but the same that the stuff we have spoken about in the last 40 minutes or so, the expectations, the objectives of Holden Fitzgerald, I would imagine that applies to, and you mentioned Latin American and the Caribbean, right? And I know personally that a lot of what you're doing now is African Saharan African based. The Caribbean, what's next? How do you do for the Caribbean what you are doing in Africa? Caribbean, Latin American, Caribbean. And correct me if I'm wrong, you may be in certain spots in Latin America. So let's spend the next couple minutes speaking about that region. What's your plan for Caribbean, Latin America, as it relates to global public health? Yeah.
So right now we are working on a project between Costa Rica and Nicaragua. We are currently working on a project in El Salvador, Peru, Argentina, and Enoch, as you know, is building our team between Sao Paulo and Salvador, Brazil. So we do have aspirations in Latin America, and Anna Ortiz, an incredible asset, is really helping us build that. So with the Caribbean's really important. We are, and I will say, kind of premise this, you know, we're in the process of, like, very quickly, completely divesting all corporate and professional liabilities in the United States.
Okay.
There's a reason for that. It doesn't really matter, but like, people need to know we're not a US company. Like, that's not who we are.
So I have two questions for you. One is, when do you plan on coming down to the Caribbean? Two, and I hope no one is sitting close to you. Some folks who saw you on the cover of our newsletter want some more personal details about you, but I'll just direct them to your email, and they can ask you all the personal questions they want.
Well, I am taken. I am a Sagittarius.
I never said what type of personal question.
No, I'm joking. I like long walks on the beach.
Without a dog. But to that actually is a fantastic note to end on. So Dr. Ryan Paul, I want to thank you for taking the time. I know you're a very busy guy, to chat with us on Risk Unfiltered. On a personal level, I look forward to us meeting somewhere in the Caribbean in the next couple weeks, not months, not years, because now you're literally much closer. You are a colleague, a friend, and there's much that we can do together to enhance, make more robust public global health, specifically Latin Caribbean and Africa. And there's much more to discuss, and we look forward to having you back again. What's your last words to our listeners?
There's a lot going on in the world, and sometimes all of that seems very uncertain. We all have a lot of different feelings about a lot of different things. But what we need to remember is that there is a middle ground, and that middle ground is to love and respect each other, to understand that we will not agree on most things, but what we can agree on is that we are all humans and that we all have value because we have breath in our lungs. And so with that, I hope that you all have a blessed day.
Great. Thank you.